Welcome to this teaching video on alcohol misuse. We will be looking at the following aims. Who is more likely to abuse alcohol? What happens to the body abusing alcohol? Why would a person abuse alcohol and why can't they just stop? In the UK, thousands of drinkers are dependent on alcohol and only a small percentage of these receive treatment. The mortality rates are higher for those in their 50s and 60s, and alcohol is often linked with violent crimes, as well as 14% of road traffic accident deaths involving alcohol. In the UK and many other countries across the world, we see alcohol as socially acceptable in comparison to other drugs where it generally wouldn't be socially acceptable to go to a bar or a restaurant and take drugs. These are the current unit guidelines in the UK. They are now the same for men and women, so men and women are advised not to regularly drink more than 14 units a week. As you can see, this equates to 6 pints of beer or 6 glasses of wine with 175 millilitres. So how much is too much? For thousands of British people, their alcohol use extends beyond those guidelines and beyond that of an occasional drinker or a social drinker. They develop a compulsion and addiction to alcohol, or what we might term as an alcohol misuse disorder. Generally, the criteria for when alcohol consumption becomes a problem is when the drinking is problematic despite the harms caused. The person builds up a tolerance and they experience withdrawals from alcohol. Alcoholism affects the way a person's brain functions and significantly impacts upon their personality, their mental health, and their behaviour and ability to function in life. This leads to compulsive patterns of seeking alcohol despite the harm it's causing to their life and their health. So what sort of factors mean that somebody is more at risk of developing an alcohol misuse disorder? There are biological factors. There's a close link between alcoholism and genetics. So some research suggests that you're more likely to become an alcohol dependent or misuse alcohol if it runs in your family. Environmental. There has been research that suggests that a person's proximity to alcohol retail stores increases their chance of alcoholism, as well as manufacturers who bombard the public with advertisements that fuel social acceptability. Social factors. Culture, religion, family and work influence behaviours such as drinking. Family plays the biggest role in a person's likelihood of developing alcoholism. Children who are exposed to alcohol abuse at a young age are at more risk of falling into dangerous drinking patterns. And psychological factors such as how well a person copes with their own emotions or people with existing mental health issues. For those that are suffering with alcohol dependence, the withdrawals from alcohol can be severe and can be fatal, as many of you will already know. We have patients that come into our ward who are experiencing withdrawals from alcohol. These can be categorised into autonomic symptoms, motor symptoms, awareness symptoms and psychiatric symptoms. So we have autonomic symptoms such as tachycardia, dilated pupils or hypothermia. Motor symptoms, classically a hand tremor or maybe a full body tremor or even seizures. Their awareness is impacted, so they can suffer with delirium, disorientation, and they can suffer with psychiatric symptoms such as hallucinations, paranoia, severe anxiety, and severe mood instability. There are mild alcohol withdrawals, which onset 3 to 12 hours after the last drink. This can be agitation, hand tremor, sweating, nausea, fever, tachycardia, high blood pressure, and a general feeling of being quite unwell. For some, this can just be like a very bad hangover. On the other end of the spectrum, we have severe alcohol withdrawals. For this, we may see patients that are suffering from hallucinations. They may be suffering from tonic-clonic seizures. We should most definitely be aware of delirium tremens, frequently referred to as DTs. Sometimes this is thrown around for people that aren't alcohol dependent. People sort of make a joke of it and that they've got the DTs, but it is actually a really severe condition. People will present with confusion, hallucinations. Usually these are tactile hallucinations, so it may be a sensation of insects crawling on the skin. They might have a marked tremor or a full body tremor. They might suffer with delusions, but they will also have tachycardia, high blood pressure, and probably profusely sweating. The mortality rate for DT is 10 to 15% if it goes untreated, and the time of onset for this is 12 to 18 hours after the last drink. These are the risk factors that put somebody at greater risk of experiencing this level of severe withdrawals. They may have severe dependency issues. They may have multiple previous admissions for alcohol withdrawals and detox. They may have self-detox without medical input, and they might have a previous history of DT or seizures. These are the associated physical disorders from alcohol abuse: liver damage, pancreatitis, GI bleeds, high blood pressure, Wernicke's encephalopathy, Korsakoff syndrome. The bottom two are a result of severe thiamine deficiency. Here we have what's called the seesaw of alcohol tolerance. So alcohol affects neurotransmitters in the brain, GABA and glutamate. So the body maintains a normal state of balance of GABA and glutamate. GABA has a calming effect, whereas glutamate has an agitating effect on people. So when you drink alcohol, GABA levels go up, leading to feelings of relaxation, calmness and sociability. And then the next day, those GABA levels are going to drop back to normal. But for somebody who's drinking every day, the GABA levels are going up and down, up and down, up and down. So in this person who's been drinking every day, the glutamate levels have now started to rise. So when they've been drinking, the next day they will then experience withdrawal symptoms like tremor, agitation, irritability at a more mild level. And then that person is going to want a drink, because that drink is then going to increase the GABA level again. So how do we increase it? Have another drink. But more alcohol is going to be needed as time goes on to reach that desired effect. And then meanwhile, withdrawal risks are much more severe. Particularly if we know that that person's had many detoxes, we know that in the past they have had a seizure during detox. The body remembers this and they're much more likely to have another seizure. So now let's talk about alcohol dependency. GABA and glutamate are neurotransmitters, and they both work on neuroreceptors as part of the neuron pathway in the brain. Here, the seesaw of alcohol tolerance shows the body that has too much GABA and not enough glutamate in a person who is drinking daily and has built tolerance. The body recognises that there is too much GABA, so it decreases the amount of GABA neuroreceptors. And it recognises there's not enough glutamate, so it increases the amount of glutamate receptors. This brings back a balance in the body, but this person is now alcohol dependent, and alcohol has been required to do this, to bring this normal state back, well, seemingly normal. Now let's say the person stops drinking suddenly. The body reacts by not producing enough GABA, and the glutamate levels are high, so the withdrawals begin. And now there is no alcohol to increase the GABA levels once more. The brain enters what is called a state of autonomic overactivity, where the patient is then at risk of delirium and seizures. Dopamine levels also increase, and this leads to hyperaroused autonomic activity and hallucinations. So when we're treating these patients, we often use benzodiazepines, such as chlordiazepoxide, and these fire up GABA receptors in the aim to bring back that state of balance again. Nursing alcohol-dependent patients can be very challenging psychologically for us. This is because we might wonder, why can't they just stop? Or why is it so hard to just stop? So addiction often originates in pain, emotional pain, either felt openly or hidden in the unconscious. So the alcohol is acting as an emotional anaesthetic. The person often has a pre-existing vulnerability. So just as food doesn't turn a compulsive eater into a compulsive eater, there would be an underlying vulnerability for this, and alcohol becomes a mean of filling a void deeply rooted within. There lies the argument of nature versus nurture. Research suggests that the child of an alcoholic is more likely to go on to suffer with addiction themselves. So this could be due to genetics, or it could be learnt behaviour. We'll never really know that answer. Alcoholism is a disease of the mind in many ways. It acts on the reward pathways in the brain, providing instant relief and positive rewards for the person. So, as I've said before, alcoholism affects the way a person's brain functions and leads to compulsive behaviours. Ultimately, the root cause of their addiction is to find a void filler. Life without alcohol becomes unbearable. The person loses touch with their true selves through chronic alcohol use. They are so consumed by their addiction that they can live in a state of denial over the severity, sometimes for many, many years. Possible treatments for patients who present to us for alcohol withdrawals with a range of severity in symptoms include a detox regime, as we all know, Abranex, which is a high-potency solution of vitamins, particularly important for the thiamine deficiency. Ongoing observations of withdrawal symptoms, and this is a key thing for nurses to be aware of, that as nurses, when we're out with the patient on the wards, we can spot signs of withdrawals and possibly request that the person has more PRN, which would most likely be chlordiazepoxide. And within the hospital, we have the alcohol liaison team. Nursing interventions. As it says here, nursing care is critical in the management of alcohol-dependent patients. Nurses can have a huge positive impact upon their recovery and helping them to find the right path towards it. As best we can, we should try and offer a calm and reassuring environment, particularly for patients that are very distressed and agitated and anxious with their withdrawals. We should be observing for signs of dehydration. We can also be offering very brief psychological interventions such as goal setting. We can also be motivating our patients to try and find recovery and tell them that it is possible to reach sobriety. We should also have self-awareness of our own negative perceptions. Maybe we have negative perceptions of this patient group. Maybe we think that there's no hope for them, but this can impact upon the care that we deliver. Longer-term treatment for alcoholism after they leave us might include support groups such as Smart Recovery or Alcoholics Anonymous. There may be rehabilitation programs, although there does become issues around finances and funding. Finding a funded place is very, very rare at the moment, and often people don't have the funds to pay privately. There are different types of medication available, and long-term therapy is definitely something that somebody should consider in their recovery, and this helps to address the underlying root cause of their addiction. Here are some examples of local services. Alcoholics Anonymous, which we know as AA. This is a fantastic service for people. It's free and it's run by people who have been through alcoholism themselves, so they have a great understanding of what it's like, and people can respond much better to this than having professionals tell them to not drink when they feel like the professional doesn't understand them. In Derby, we also have great resources for alcohol recovery and drug dependency as well. So recovery is possible and a life of sobriety is achievable. The only person, though, that can ultimately make that change is the patient, but we can certainly have an impact on their journey to sobriety by demonstrating compassion, empathy and understanding. Thank you for watching.